Thank you, chairpersons. Thanks, Purvi, Manoj, and Team DRS for the invite. And in this Type 1 symposium, I'll be talking about emergencies in Type 1 diabetes. So we are going to see there are three kinds of emergencies what we see in day-to-day practice. First is DK, diabetic ketoacidosis. Second is HHS, and third is hypoglycemia. So my talk primary will be focusing on DK because that is what we experience in day-to-day practice, and my presentation will be a typical of practical tips what we are going to do in our clinical practice. So DK is basically D stands for diabetes where blood glucose more than 200. K is for ketosis where there is a capillary or blood ketone concentration more than 32 or there is a significant ketonuria. And A stands for acidosis where bicarb concentration is less than 15 or the venous pH is less than 7.3. So by this, the patient has a DKA. Diagnosis wise, it's a more or less a biochemical kind of diagnosis where we rely on more of these features of blood glucose, acidosis like bicarb, pH, and then ketones. But though there are clinical signs also like symptoms where polyuria, polydipsia, polyphagia, weight loss, breathlessness, and the signs of dehydration, cosmos breathing, lethargy, and drowsiness. But we rely for diagnosis on biochemical parameters, and once we do that, because I won't go in detail of pathophysiology, but it is basically DK starts with the absolute insulin deficiency or relative insulin deficiency in presence of stress, infection, where there is a surge of counter-regulatory hormones which increases lipolysis, by which it increases the free fatty acid to the liver, and then there is a increased ketogenesis, increased ketones, decreases the alkali reservoir, which produces acidosis. So overall, we have in DK acidosis, dehydration, and hyperosmolality. Those are three areas what we need to manage properly. There are three issues in DK management. First is dehydration, second is high glucose, and third is electrolyte imbalance. And we have three weapons for this. First is fluids, second is insulin, third is potassium. So when we are going practically about a patient where it is admitted with a critical care unit, where in the first hour, so what we need to do, first once patient gets admitted to our center, where the initial lab work, immediately after admission, take out the blood samples, point of care of blood glucose, where capillary glucose meters, we could do random blood sugars. Then blood gas analysis, preferably arterial, but venous also will do. So venous pH is also quite helpful in type 1 patients, type 1 DK. Serum electrolytes, KFTs, osmolality, and then urine deep strips for ketones. This was the first action what we need to do right in the beginning. Second is, we need to assess the severity of decay, whether it is a mild decay, moderate decay, or severe decay. So these are the characteristics by which we can grade the severity of decay. So first, we have collected a sample, and then secondly, we assess the severity. And the third thing is the basics of any critical management is with A, B, C, D, E, S. So A is airway, B is breathing, C is circulation, D is diabetes, E is for electrolytes, and S is for sensorium or search for infections. So right at the beginning, the first place, we need to put two separate lines. First for IV fluids, second for insulin. So that is a mandatory. And second thing is, after that, oxygen for shock and antibiotics in case of fever. So this is the protocol management for all sorts of DK patients where you should follow this. And in detail, the primary focus of the treatment will be like these 5 factors where fluids, potassium, insulin, monitoring, and transition. So this is the way we should approach our DK patients. First and foremost is fluids. Many times what happens, a RMO or a duty doctor sees a value of 550, 400, he's stuck, insulin. So insulin is not the first modality. It is the first is only fluids. The fluid resuscitation is the cornerstone of diabetic decay management, and the fluid of choice is 0.9% normal saline. So first fluid is normal saline for first 2 hours. 1 to 1.5 liters per hour for the first hour. So that's got to be dictum. So any patients of DK, don't start immediately insulin. We need to give at least 1 to 1.5 liters for first hour. For pediatric use, more cautious approach, that is 10 to 20 ml over first hours is required. And our aim should to replace approximately 50% of the estimated fluid loss in the next first 8 to 12 hours. So that should be our aim. So replenish all fluid within 8 to 12 hours. So monitoring is very key, where signs of fluid overload, especially the elderly or heart failure patients, we need to be little watchful. Now, what sort of food? Because first you start with normal saline, and then there is question, kya half normal saline istemal karna hai, when to change the DNS. But the dictum is, first few hours normal saline, and then, because according to the sodium, potassium, because we are doing it right in the first place at the time of diagnosis, second after 4 hours, and at the end of the 8 hours. So 3 electrolytes are mandatory for DK patients. So at the end of 4 hours, you need to again repeat the sodium and see for the corrected sodium. If the corrected sodium is still on the lower side, you continue with the 0.9% sodium. If corrected sodium is on the higher side, that means you switch over to the half normal saline. Once blood sugar gets below 200, 250 range, then switch over to the dextrose containing fluids. So that's a simple way of managing with normal saline or half normal saline or DNS. And second step, I have not started yet to insulin. Second critical step is about potassium, because potassium is the key factor, key management as far as DK is concerned. Where we should aware that we have large potassium deficit in DK. So overall, the management should replace on the basics levels, like if potassium is less than 3.3, if it is between 3.3 to 5.2, or if it is more than 5.2. Suppose, because if overall at the time of admission, suppose the potassium is around 4, patient, even duty doctors or many consultants, they feel like, potassium to abhi acha hai, kyun dena hai? But that is not the dictum. Where even with the 3.3 to 5.2, there is a 40 milliequivalent per liter potassium has to be infused. And if, this is the critical phase, where if the potassium is less than 3.3, don't start insulin. So insulin should be avoided, should be deferred at least for 2 hours. Repeat potassium once again and then start, because it is a criminal to start insulin drip when potassium is the less than 3 or 3.5, because it can cause arrhythmias and all those issues. So less than 3, don't start insulin. 3.3 to 5.2, you can give 40 milliequivalents per liter. That is the overall potassium management. And if the potassium is more than 5.5, then wait for kidney functions and urine output. So I hope this is the important management about potassium. Nowadays we are not using bicarbs anymore, because the bicarb use is recommended only for the severe acidosis, where pH is less than 6.9 with severe hemodynamic instability. Phosphate also we are not using, we are not generally recommended. The step 3 is insulin management, where we used to, again, it is for the metabolic switch. You can start with the continuous IV insulin infusion at the rate of 0.5 units per kg per hour. And the critical rule we have just mentioned about potassium, you should not start potassium, you should not start insulin when potassium is on the lower side. Once blood sugars are below 200 to 250 range, then switch over the dextrose containing fluids. As far as insulin is concerned, there is no role of IV boluses more. Don't use insulin for the first hour. That should be the management, only fluid for the first hour. Continuous IV infusion through the separate line, because you maintain 2 lines. Dose we have already discussed. Regular insulin is what we are using continuously now, because that is the recommended insulin. And how long it should be continued insulin to be continued till the resolution of acidosis. Care to be taken when blood sugar goes below 200, switch over to dextrose containing pints. The final step for safe discharge is when glucose is less than 200, bicarbs are more than 15, venous pH is more than 7.3, and anion gap is less than 12. So this is the patients who can be switched over to the subcutaneous insulin. And here point to be noted that the anion gap is the most reliable marker of decay resolutions. So do not stop IV insulin until the anion gap is closed and patient is ready for transition to the subcutaneous insulin. And what are the common complications of decay management pitfalls? Where the hypoglycemia, because many of times, young doctors are over enthusiastic, sees the reports, blood sugar 400 hai, 500 hai, took the insulin. So that kind of aggressiveness and should be avoided. Hypokalemia is another issue, because patients, many times clinicians also, forget about potassium. They only focuses on glucose. So hypokalemia is a major threatful complication. Fluid overload is another one. And we should be worried about cerebral edema, because it's a rare but a devastating, fearful complications. And whom to suspect cerebral edema is bradycardia with hypertension, the changing neurological status with a severe headache. And these are the patients where, severe decay patients where blood urea nitrogen is more than 20, pH is less than 7, PCO2 less than 21, age less than 5 years. So these are the patients of subset patients where we need to be more vigilant, because these are the cases where there is a likelihood of developing cerebral edema. So in case of cerebral edema, keep mannitol ready and slow down fluid rate. Another emergency is HHS, where there is a dehydration emergency, what we call. So pathophysiology, it has a sufficient insulin to prevent ketosis, but not enough to prevent severe hyperglycemia. And the diagnostic criteria is where glucose is more than 600, osmolarity is more than 320, pH is usually more than 7.3, bicarbs are more than 18. So there is enough insulin, but the dehydration is the key in HHS. And here the key differences between HHS and DK, where we see DK is at the younger age versus HSS at the older age. DK is a very rapid, and HSS is a gradual mode of action, where plasma glucose is more than 600 or so in HHS, where it is like not that big, big 250, 300, that's all. pH less than 7.3 and pH is more than 7.3 in HHS. And osmolarity is the issue in HHS, where we see osmolarity more than 320 in HHS. As far as management is concerned, here the key is aggressive fluid resuscitation, where the primary focus is just fluid replacement, where patient has a much larger fluid deficit to the tune of 8 to 12 liters than DK patient. So just push more fluids and start insulin drip at a lower rate. It should be like 0.05 units per kg per hour. That should be the insulin drip rate for HHS. Here the mantra for HSS is only fluids first. And potassium management is more or less same as far as TK. The third emergency, it is very common in type 1 diabetes, is hypoglycemia, where blood glucose is less than 54. ADA definitely have a tired definition for hypoglycemia, where level 1 is less than 70, level 2 is below 54, and level 3 is a severe event with an altered physical or mental status. But it is a more common emergency than DK, hypoglycemia, but hypoglycemia, where golden minutes in hypoglycemia is very crucial, because every minute is crucial in hypoglycemia, because we should not deprive brain of glucose. That should be a dictum for all clinicians. So patients should not have any kind of hypoglycemia. That should be our primary aim. When in severe hypoglycemia, in case of conscious patients, where 15 gram of fast-acting carbohydrates like glucose tablets, juices can be given. Unconscious patient, community-wise, glucagon administration can be taught to the patient's relatives in communities. Unconscious patients in hospital setting with IV 25 dextrose can be given. This is the management what we usually practices for hypoglycemia. And there is, everyone is aware of the rule of 15 for hypoglycemia, where consume 15 gram of fast-acting carbohydrates, wait for 15 minutes. If blood sugars are still on the lower side, then again repeat the same procedure. So the hypoglycemia management, as we have discussed. And these are the final takeaways from my presentation. In diabetic emergencies are of 3 parts: DK, HSS and hypoglycemia. As far as DK is concerned, fluids first, fix the potassium, and then the insulin. So that should be the flow for our management. Don't run for glucose first. Wait for hydrate properly, and then start insulin and adjust potassium accordingly. HSS, the fluids are top priority, but here use lower insulin dose. That's the key for HSS. More fluids, less insulin. And hypoglycemia, recognize early, treat fast. Prevention is of paramount importance. To summarize, overall, I have seen that now we have to follow the protocol-based system rather than individual instincts. We should forget all individual instincts and go with a protocol-driven system, because now with the DK and overall, if you see, the protocols are very clear. The first sample, then monitoring 4-hourly, 8-hourly, 12-hourly. Ideally, one should able to resolve DK within 24 to 48 hours, because insulin being a ultrasonic mimic action where it causes more of potassium losses. Our aim is to cut short transit from IV insulin to subcutaneous insulin as early as possible. So that should be our motive, and that's a protocol-driven system is the key. But never forget the clinical context. Thank you so much for your patient listening.